This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. This is the third instalment of mental health in pre-hospital care. And in today's episode, what we're going to do is look at some of the wide-ranging mental health pathologies and or conditions that paramedics and pre-hospital staff really experience and indeed engage with on a patient level. So from anxiety to depression to psychosis to self-harm, the ability to quickly assess and indeed manage these conditions is crucial to ensuring best possible outcome for the patient. So one of the questions today we're going to ask is how we really navigate the complexities of mental health in the field where resources are limited and indeed time is critical. So we're going to look at some of these most frequently encountered mental health pathologies, but also how we assess, manage and indeed provide care for these patients. Also looking at some of the common pathologies really around anxiety attacks to bipolar disorders and indeed some of the unique challenges we face in the community dealing with patients experiencing severe psychological distress. So I'm joined again by Kylie Lynch and Dan Phillips. Welcome both to the podcast.
Hello, thanks for having us back.
It's fantastic to have you both with us. I just wanted to kick off actually. Kylie, I'll come to yourself, just around a framing question really, and just get you to speak to some of the most common mental health conditions paramedics encounter. And I guess the frequency question is, how frequently do they occur?
Thank you. Yeah, so I think it's important to say that what we often see in the pre-hospital setting in terms of kind of mental health conditions is acute distress or deterioration. And within mental health services, we wouldn't necessarily, give somebody a diagnosis after meeting them once or maybe even twice. There might be a kind of longer term assessment in order to kind of make a diagnosis. So we definitely encounter people in the pre-hospital setting that maybe have never had any kind of mental health history before, and then obviously there are conditions where that there will be a kind of diagnosis such as depression and anxiety, and then mood disorders as well. So that, as you mentioned, kind of bipolar disorder is a common disorder that we may come across. And when we did a big kind of audit into the kind of patient sample size, a big sample size of patients that we saw, we found actually the most common presentation that we saw was psychosis, and then closely followed by kind of personality disorder presentations, and people who live with a personality disorder can experience kind of extreme kind of mood fluctuations. So by the nature of their illness, they may present to the pre-hospital setting if they're unable to kind of self-soothe and regulate their emotions, and they'll feel very overwhelming distress, so that they may call us for kind of help. We may also see presentations related to kind of drug and alcohol as well, and there is a close overlap in a lot of circumstances where people may be using substances and then go on to develop conditions such as psychosis, for example, or people on the converse may have a mental health condition and then be kind of self-medicating with drug and alcohol. So there is a huge overlap as well. We're also seeing a kind of increasing trend in chemsex related incidents, and our team is definitely seeing more patients who have become addicted to those substances and then potentially develop things such as kind of psychosis as well. So as we've spoken about earlier, we can't separate the mind and body, and we know that kind of nearly half of people who have a mental health condition that's chronic will also have a physical health condition as well. So it could be that, that there is a physical health cause and it's manifesting as anxiety, but actually the patient's probably quite anxious about how they're feeling. So yeah, we have to kind of, do a thorough assessment to work out what's happening. So there's no diagnostic overshadowing. We know in London that mental health is around 10% of our workload. I would say that would be potentially an underestimation, just of the way that we kind of code our data, but it is increasing. And over the past year, our mental health demand has gone up by 40%. So there's a huge kind of demand for mental health services. So yeah, it's busy for mental health. We are predicting that this rise will continue, and we're working hard with our partners to kind of make sure that people are accessing the pathways that they need to in order to kind of prevent them becoming, acutely unwell or in a crisis. So yeah, it's busy in
Yeah,
summary,
no, indeed.
and the way that we teach our crews really is, and we'll go into some detail about condition specific things today, but it's important that you're managing, what's in front of you. And I think obviously in the pre-hospital setting, we quickly have to like build that rapport, get some background information, make that person feel calm and supported and validated. And a lot of our patients will also have had history of, not having maybe trusting relationships with people. There may be some trauma there. So it's how we can quickly build rapport and ease that distress. And obviously the diagnosis, yes, is important, but it's about treating that person in front of you and making them feel kind of, as better as you can do in that situation.
Yeah, indeed. And as you speak to, this symptomatology might be anxiety, but there might be an underlying diagnosis, a formal diagnosis. But you're right, addressing both or acknowledging both, but it's very much dealing with the here and now. Carly's was saying, Dan, I'll come to yourself and just ask you about that actually, if that's okay, just around some of the ways or indeed key symptoms to look for in a patient experiencing acute anxiety.
Yeah, absolutely. Thank you. It's a great question. So first of all, I guess starting with, the sort of signs, symptoms of, panic attack, anxiety attack, or, hyperventilation syndrome. We'd expect to see a patient, probably with, a debilitating sense of panic. They're probably going to be seeking some sort of reassurance, and there may be some sort of like fixed thinking, or quite blinkered vision on sort of like the issue or the sort of the trigger for the situation. Again, very common, sort of a very common symptom that we're likely to see again will be patients will report sort of feelings of like tingling in their hands. In terms of observations, we'd probably likely see an increased breath rate and an increased heart rate. We wouldn't expect to see other observations necessarily sort of deviate from normal. And again, if I'll come on to sort of risk of diagnostic overshadowing in a minute. But again, if other observations are out of kilter, or those observations sort of don't return to normal with sort of some basic coaching, then we'd probably start to think that maybe there's something else going on. And again, with these patients, there's also just a risk of sort of impulsive behaviour occurring, sort of due to this sense of panic and sort of people sort of needing to do something, and yeah, catastrophizing, so, sort of about the future and sort of outcomes and sort of what's going to happen next for them. So yeah, so the real key thing here is sort of obviously after an initial primary survey and sort of establishing sort of your baseline and where things are at in terms of oxygen saturations and base your basic primary survey. We would want to focus on providing reassurance to the patient. Possible, can we move to a calm location? Can we remove, is there an obvious stressor or stimulus that sort of is it causing the situation or exacerbating it, and can we remove that in order to try and sort of help the person, reach some level of calm and de-escalate. We'd want to look at sort of trying to help them coach their breathing, and sort of talking them through sort of nice slow breaths, deep in and out, and sort of seeing if we can sort of break the sort of pathway that's going on in their head, and sort of try and bring them back and to us, and get them trying to control their breathing better. And then obviously want to take sort of full physical observations and a respiratory exam. This kind of then links in nicely to the point that I alluded to on diagnostic overshadowing. And it's really important sort of early on in the assessment that we sort of rule out other conditions first. In the context of an anxiety attack or hyperventilation syndrome, we would, I guess, the sort of like one of the main things that we need to sort of have, be really conscious of is the risk around like a pulmonary embolism. So if we're seeing elements such as low oxygen saturations, or as we're sort of trying to coach the patient's breathing, things are not resolving, then we sort of want to have a low threshold for suspecting that there's something else is going on, and look at actually, if things aren't resolving relatively quickly, we probably want to start thinking about what's our next plan of action here, and do we potentially need to look at going to A&E if we can't get things under control, with those sort of simple measures. And as sort of J.R. Calc says, always presume that hyperventilation is sort of secondary to sort of like an underlying respiratory or other metabolic disorder until we've proven otherwise. So it's a diagnosis of exclusion. So always have a good threshold for assuming something else is going on until proven otherwise. If we can de-escalate and get observations all back to normal, and the patient is calm, and we can sort of look at managing them at home. And then if we sort of unable to control things or unable to safely de-escalate and get the patient sort of back into the place we want them to be, or like I said, sat still decreased, then we sort of be wanting to look at, in terms of our care plan, sort of moving to another location where the patient can receive sort of follow-up treatment or assessment.
Carly, could I get you to walk us through just a patient, maybe, as you were saying before, quite commonly presenting with indeed either delusional behavior or indeed psychosis in the pre-hospital setting? Could you just walk us through your sort of mental model of how you would approach that?
Yeah, so obviously it is a case by case, approach. And I think it's really important. There's kind of two things immediately that just to reiterate that, whatever the person is experiencing is real to them at that point in time. So it's not really helpful, if there may be, I don't know, hearing a voice or, having some particular belief in terms of delusional thinking. It's not really helpful to get into the cycle of saying, oh, it's not real, because at that point in time, it's very real to that person. So it's important that we'd start validating, and obviously we may know that it's a psychosis or some kind of delusional thinking, but just to say to that person, if I was experiencing that, I would potentially feel quite scared or quite anxious. So just to kind of validate that person. And then the second thing that I would really be looking for as well is the insight into that situation. And because although it's real to that person, if after a kind of thorough assessment and engaging with that person, if you're talking to them about any kind of diagnosis they may have, for example, they may have a diagnosis of schizophrenia, I would be asking them, like, do you agree with that diagnosis? What's happened in the past if you've had a relapse? And then say, some of these things that are going on are really stressful for you. Do you think it could be related to your schizophrenia, and maybe you're having a relapse? And that's a good way to kind of test the insight of the person, and how workable they are, really. And then in parallel to that, we would also need to assess the risk, and things that I would be very concerned about is if a patient is having kind of what we would call command hallucinations, so they're hearing, what we call voices telling them to do something. And we know that is incredibly risky, because patients, if this goes on for a long period of time, it's incredibly distressing, and patients can go on to kind of act on these hallucinations. For example, jumping, or being told they can fly, and they may kind of jump from a high building is an example. So they're the kind of things that I would start to look at that time. Also, if this is a new episode, so if there is no history, so I'd be contacting kind of mental health services and trying to gather information. I would, if it's a new presentation and there's no history of kind of psychotic, symptoms, I would be erring on the side of caution and thinking that they would need to go probably into the emergency department to have a physical health workup, because as Dan mentioned before, there's other things that we would need to kind of exclude. And also, if something has come on quite rapidly, then that is also a cause for concern in terms of, is this something of a physical health cause? Because generally there will be in a kind of psychotic relapse, there'll be a more steady decline of the person's kind of functioning, so kind of how they're managing their day-to-day life. Are they withdrawn? It's also important to recognise that we may see patients who are acutely under the influence of substances at that point, so illicit substances, and they may be kind of experiencing some kind of psychotic symptomology, and I think it's really important that we remind ourselves that is still risky, and yes, it may wear off when the drug works out of the patient system, but we would still need to ensure that we're managing the risk safely. So if they're kind of, depending on how distressed they are, what the nature of the psychosis is. So yeah, and so it's about just trying to build that rapport. And, by the nature of a psychotic illness, the person may be very suspicious and very guarded, so it can be really difficult to build that rapport. And then on the converse, if somebody is very, what we would call floridly psychotic, they may not be able to be guarded, and it's quite obvious what's happening for the patient. So yeah, we would just need to kind of do the mental state examination and look at the insight and see what the options are, really. And if a person has potentially, I don't know, stopped their treatment, we would be looking to see why they stopped their treatment. Was it because of side effects, or they felt they didn't need it? Would they be willing to have some treatment? And also kind of having that honest conversation with patients, because, I was talking about this yesterday, actually. A lot of our patients who have been, have these chronic relapsing conditions, they may have been used to, when they're starting to get unwell, they may associate that with eventually being, unfortunately sectioned under the Mental Health Act and then put on a ward. So they may become more guarded because they don't want that to happen. And they think because we're an ambulance that we take people to hospital. So quite often we'll be honest with our patients and say, look, we want to work together to try to avoid hospital. And I am worried that if we don't put a plan in place now, you could be at risk of going into hospital. And quite often that can make the patient feel quite supported, that we want to do our best to avoid this, and reassured. So then patients may be more open then about their kind of symptomology. I think I mentioned on an earlier episode, it's about who can have that rapport with the patient. So definitely, I think less is more during the assessment. The less people in the room, the better. And quite often, if you're psychotic and there's kind of a couple of staff standing in front of you, it can get, they can get quite fixated and feel quite awkward. So, if it's safe to do so, and whoever's got the best rapport may speak with the patient. So yeah, they're the kind of things that we those tips I think we would recommend for people. So yeah, I think they're the main things.
No, that's fantastic, fantastic. And like you said, there's an absolute array, but there is these general principles, and to your point around validation, but also like you said, getting the patient on board to say, look, we're here for you, and we're here to support the best outcome for you, and almost winning them over in that way. To say, well, look, we're on the same side is absolutely key. Something that I was always, like you said, around psychosis or psychotic behavior, I was always quite cautious when I couldn't get eye contact. I caught out a few times actually when there is maybe a few violent outbursts when approaching a patient when I didn't establish eye contact initially. There's a lot that can be garnered, I think, from the eyes and from really from the maybe a transfixed stare to a lack of eye contact. And I almost had a very much an internal, I don't know what it would be. It was an internal sort of indicator. If you can't establish eye contact, it was quite risky actually, especially if there was frenetic or indeed quite, they had a countenance of unstable behavior with lack of eye contact, and that would really almost, that eye contact is almost reassuring because it is the first connection to a patient consultation is getting eye contact. Dan, I'm going to come to yourself, but Carly, have you got any thoughts on that?
Yeah, I don't know whether I see your point, and just the point that you picked up. I think for me, it can be when we have patients who have that kind of fixed gaze, as we call it, when they're quite psychotic, that can be very, as a clinician, it can start to affect your kind of anxiety levels because you may start to feel kind of self-conscious, or it's quite an intense, unconscious, uncommunicated kind of act. But yeah, for me, it's about, and I guess there may be times where patients, because of maybe some neurodiversity, or because they could be quite shy, or they may not be able to make kind of the eye contact necessarily. But yeah, I guess it is something that does come up. For me, it's more when it's a fixed gaze. And actually, I recently assessed a patient. Sometimes when patients are quite psychotic, they may mimic the person who's talking to them's movements. And I'm, as you've probably noticed, I'm quite expressive with my hands when I talk. And um, the patient started to mimic my movements. So then I became kind of conscious of that and went into a more kind of contemplative pose. And then the patient did that. And then it can really start to kind of derail you as a clinician, kind of asking the questions, and just have to kind of keep it in mind. And it can really affect the consultation unless you're aware of what's happening, and just be like, okay, this is part of the symptomology, and it shows that this person's maybe quite unwell. So you're more mindful about how it's making you feel. There's just a lot goes on unconsciously. Yeah.
Absolutely. No, absolutely. Dan, to yourself, just around, we've spoken on the last podcast really about suicidal ideation. But could I get you to speak to your approach really, or just some front of mind tips when approaching someone with a major depressive disorder?
I think it's worth just by noting for these sorts of presentations, it can be really hard to initially just to get the patient to open up, or to sort of even identify sort of exactly what the issue is. The patient, they're quite often can be quite guarded, sort of report that they're fine, or sort of not want to engage. And it's not uncommon that there's, somebody else has called for these presentations, and that patients are often, people often, in extremely depressive states often aren't themselves engaging with services just because of the nature of their illness. So that they may not have called themselves, they may, because of their illness, not feel like they don't want help. So it can be quite hard to just identify initially, sort of without relying on sort of caller information or other people on scene to sort of help that initial part of sort of on your first arrival of figuring out what's sort of going on and why we've been called. Some tips of actually then engaging with the patient. The main thing is just to spend time building rapport. Don't rush. I think it's really important that if the patient says they're fine and they just want us to go, just really important just to give it a little bit of time, particularly if there's something someone else is saying or that's on the call that's just giving us that little red flag. It's just so worth just taking that extra bit of time just to build a bit more rapport and just see if we can get some, just get them to sort of open up to us. If and when we're able to sort of engage a bit better with the patient and start having a bit more of open dialogue, then I think one of the key messages is it's really important to just sort of normalize talking about suicidal thoughts and just identifying with the patient that sort of what they're going through is something that sort of we're there and able to talk about with them. A real key point and message for sort of any clinicians listening, because I think there is some, it is a worry that people have sort of from call takers through to, experienced paramedics or other clinicians, is talking about suicide does not increase the risk or likelihood of somebody going on to complete suicide or sort of harm themselves. It's just really important to have that conversation and ask the question, and then when we sort of continuing to engage with them, just sort of hold hope for them and make it sort of really clear and obvious that we are there, and although we don't know them, and although for the nature of ambulance response work we may never see them again, that we are there and we care, and we want to really support them in however we can in that moment. And then it's just really important to involve both the patient and other trusted loved ones and sort of anyone we can to sort of really establish a good history and plan a way forward. In terms of sort of clinical assessment, sort of two really key things, sort of what, once we've ruled out, any underlying conditions, again, it's initially the sort of a really good mental state examination. I think that historically these are really poorly taught in pre-hospital clinicians. But essentially, a mental state exam is designed to capture a snapshot of how the patient presented to you here in this moment, from appearance, how they're behaving, their thoughts, through to like what's their insight of their illness, and other factors. And I think a lot of people have a bit of a perception that it's a bit of a tick box exercise, but actually, mental health trusts really use that information to track either the improvement or deterioration of a patient. So it's really important that we're sort of conducting and documenting good mental state examinations. And if we're handing over to a service that, they may not be able to see our paperwork, that we're conveying that information sort of over the phone as well. And then also moving on to to a thorough risk assessment covering risk to self, risk to others, and risk from others, and also then covering sort of critically sort of protective factors and sort of safety netting options. And in terms of the risk assessment, what sort of positive things can we do to, if we're thinking about not conveying to hospital, how can we keep this person at home safely? What factors are there? Do they have pets that they or loved ones or other people on scene who can look after them or that give them hope, and sort of little bits like that. And I think the real key thing for this patient group, sort of once we've completed our assessment, and I think probably for all the patient groups that we'll to sort of discuss, is just the importance of speaking to services, sharing the information from our assessment, gaining more assessment from them, and more importantly as well, sharing our decision making with mental health trusts and the mental health teams and single point of access. I think things go wrong when we try and work in silos. So we need to be gaining more information to establish how does today's presentation match up with their past history, and sort of when we're weighing up our risk assessment based on what they know about the patient's past risk, how does that link in to if we're leaning towards do they need to go to hospital, or is this person, I think this person may be safe to leave at home with follow up. Do the mental health trust, the experts in this, do they agree with that logic? Can they sort of validate that decision, or actually is there something small that something that seems sort of small to us on scene, but actually upon reading past sort of history and presentations, is there something that they're like actually giving them sort of bigger red flags where either they need to step up their response or acknowledge that actually that they cannot respond in a safe time frame, at which point we may need to then sort of consider going to ED. So I think, yeah, the main thing, just to summarize, is just share as much information, gain as much information. It's, often a bit of playing detective work, and then sort of sharing and making that decision with sort of as many people as possible, to sort of make sure, the decision is safe.
So just pivoting slightly, Carly, coming to yourself, on the last podcast we spoke about suicide and suicide prevention and risk assessment, and just a facet of that I'd just like to ask you about really is there is quite a high frequency, certainly in urban populations like London and otherwise, of patients with deliberate self-harm. Now that might be physical self-harm, cutting, or it might be indeed maybe pharmacological self-harm, taking tablets or otherwise. Could I get you to speak to really just how we manage it? And the problem is here, it is a spectrum. And, with the history of deliberate self-harm, there's probably red flags you can acknowledge. And in an absence of history and a first presentation, there might be other indicators which they actually do need significant attention. But can I get you to speak to your approach really around self-inflicted injuries, either either pharmacologically or physically, just what's front of mind for you?
Yeah, so I think it's important to start off by saying that what I will say now is slightly contradictory. Self-harm is separate from suicide, but people who self-harm in the longer term are a more increased risk of dying by suicide. So I think the first thing that I would be kind of looking to establish is around the kind of intent. So, when the person did the act, and as you said, it could be they could have maybe potentially taken an overdose or maybe cut themselves. And I think you did a bit of a Freudian slip and you said psychological and then stopped yourself. But absolutely, people can do psychological self-harm. They may kind of, restrict food intake or be quite self-punishing. So yeah, it can also be a psychological kind of concept as well. So yeah, I think the intent is the first thing that I would be definitely kind of looking for, and also around the fact that this is about finding the person, accepting the person how you find them, and it's really important, and we know from a lot of engagement with kind of patient service users, and it's well kind of documented that historically, I think that people who had self-harmed or self-injured felt that they would often have quite a negative experience, in emergency departments and even in the pre-hospital setting. And sometimes there would be kind of judgment passed on, why have you done that? Like, you shouldn't do that. But it's just about kind of accepting that the person for what for what's happened to them, and to try to find out why they did this, what the intent was, and then to try to obviously assess what needs to happen in terms of if it is a physical kind of injury or overdose, kind of what needs to happen. And there will be a group of patients who will, chronically self-harm, unfortunately, and that's really distressing for them. But it might be a way that they manage their emotions, as I mentioned earlier. If people are kind of emotions are dysregulating, then it may be a way to try to contain how they're feeling if they're feeling quite out of control. Patients will also tell us that they may feel quite numb, and not feel anything, so they may do something to inflict some pain. That does happen as well. And then also to self-punish if people think that they're kind of worthless, or they have low self-esteem, or a negative incident has happened in their life, then that might happen as well. So yeah, and it's important if this is a kind of chronic picture to establish, as I said, what usually happens for that patient, what's their baseline. Obviously we want people to have treatment and therapy that may help them to kind of overcome this self-harm and self-injurious kind of behavior. But whilst that's going on, what's the kind of baseline? And if things are getting worse, for example, if somebody's cutting in a deeper way, or in a different area of their body that would be more concerning to us in terms of kind of immediate injury, then we'd probably think actually we need to do something here and review the care plan. So yeah, it's a complex kind of situation, and we know, and the guidelines tell us that if people have self-harmed in some way, they should have a kind of full biopsychosocial assessment as well. So yeah, and it comes back to the point that Dan was making around engaging with mental health services to see kind of what the risk is and what the plan is as well. So that's key. And just something as well that has come up before, obviously things such as cutting your arm, for example, that's generally more obvious to us, but if patients have said that they've taken an overdose, I think we would really be encouraging them to go into hospital, because often if people are very distressed and very upset, they could be very tearful or feeling a lot of emotions, and maybe they've taken some tablets. In the heat of the moment, they might not remember accurately exactly how many tablets they took or what they took, and people's kind of memory, yourself, if you're really distressed, your memory is not as sharp as it is. So yeah, always I would think err on the side of caution as well, that the patient may not fully remember what was taken because of how distressed they were. So yeah, obviously we need, and it's hard to rule out any harm from an overdose. With the kind of tools that we have on an ambulance, it would usually require kind of blood tests or kind of further monitoring. So yeah, that would be my views on that. Yeah.
No, fantastic, fantastic. So just before we just pan out slightly and look at maybe some of the wider learning that's shared with mental health teams, Dan, I'll just come to you finally, just for a pathology which is again quite common within London and other major cities, is really around bipolar disorder episodes, either the manic or indeed depressive phases of bipolar. I often found it was interesting to see sometimes the tablet compliance or lack of tablet compliance maybe in these episodes, but it can be trickier than that, because to Carly's point, that they may not have a formal diagnosis, and actually this might be the start of a formal pathway to diagnosis. But could I get you to unpack really some top of mind tips really when responding to bipolar disorder?
Yeah, absolutely. Thank you. So I think it's worth starting off, just to sort of not sound sort of too repetitive for your listeners, but I think some of the approach here will be quite similar to some of the previous presentations we've discussed, in the sense that it'll be a very patient-specific approach. There isn't one size fits all often. So I think for a patient that we're encountering where we think they may sort of be experiencing like a manic episode, it would be sort of again trying to use those de-escalation techniques and trying to sort of offer as much reassurance and trying to sort of contain the situation as much as possible, and working with the patient sort of to try and establish the best way forward. And then for a patient with sort of bipolar or suspected bipolar disorder experiencing a depressive phase, it would be sort of similar to my last sort of answer around the approach that we discussed for a patient experiencing a depressive episode in that sense. For, I guess, either presentation here, it's again about assessing the risks in the moment, and sort of weighing those up against the protective factors. And obviously, the risks for each phase, will be potentially quite different. Sort of, I guess in the manic phase, we may sort of be sort of seeing more risky behavior or risk of the patient sort of coming to harm because of yeah, that sort of risky behavior, sorry. And then sort of like, again, the depressive patient, we may sort of have more, we need to be sort of more mindful of, the risk of sort of self-harm or suicide. And just as you just sort of mentioned around tablet compliance, and could this be sort of a first presentation and there being sort of no diagnosis? Again, if this is a suspected first presentation, we can confirm that by calling the single point of access or the local mental health service. But yeah, again, if the patient doesn't have a diagnosis, then this will almost certainly need further sort of physical investigation before going for like a mental health assessment. So to sort of really being mindful of underlying causes, particularly in an older adult, or an older adult, it's actually relatively uncommon for an ambulance crew to encounter the first presentation, but we do. So in those instances, we will need to just make sure that the physical health is fully covered, and that may sadly require A&E just to be able to complete that. And then it comes back once again to discussing with mental health services, and on scene, assuming there isn't that obvious red flag that requires like an immediate transfer somewhere. It's asking those questions and just some tips and some questions people sort of may want to ask, sort of for these groups and for other patients as well. So we asking about diagnosis. Do they have a diagnosis? What's known, what's not known. What is their past history and their past risk history critically? And then again, how do both of those compare to what we're seeing today? Are there other recent presentations that the mental health team are aware of, or is there actually a known relapse that's currently ongoing? Services may already have been alerted to sort of the fact that something's deteriorating if the patient's known, and then asking about the patient's baseline, and then again, what sort of if we think about on a good day, how does this patient present, sort of like when they're well, and then what's the deviation from that? And then I guess a key question, if a patient is known, is there a current plan, and are they currently open to a team? If the patient is under a team, or actually we find out that the patient already has a planned mental health act assessment, then hopefully that means that if that's within a suitable time frame, then that would actually be the appropriate thing for that patient still, rather than sort of conveying them to an emergency department. And then again, like a key question to always be asking the mental health services, what do they think is a good plan for this patient? As they're the experts in these presentations and have access to more information. And then for the patient in a manic state, is also worth just asking sort of around, asking sort of both the service and the patient sort of around their sleep, and sort of other issues that we may encounter that's worth just sort of addressing. It can be sort of extremely detrimental to the patient's physical health if they're unable to sleep for like very long periods. So it's always worth just asking about their sleep patterns as well.
Yeah, Dan, I firmly agree. I think sometimes we underestimate the adage of sleep and the importance of sleep, and actually, that itself can be an origin and a source of mental health, acute mental health issues. Carly, so just as we come into land, a couple more questions. One, Carly, really would be a pivot from what I initially wanted to ask, because we have addressed a lot of these, to Dan's point, a lot of these MDT approaches, and I think it's a great shift to see. It's becoming standard practice now that we do reach back into in a lot of pathologies. So critical care, acute physical health, mental health. We're really involving an MDT approach as when it's appropriate to do so. Could I get you to speak to if there is what level of integration at the moment, Carly, there is from yourself, or indeed you and Dan, or from a trust level with the wider mental health community teams, from just information sharing, from lessons learned, from case studies, to really share some of their learnings from the community and or hospital based back into the ambulance service, because there is this bilateral sharing of information. There's a lot that mental health teams can learn from pre-hospital presentations, that's really informative, from seeing patients' homes and some of the key learnings. But there is this bilateral learning.
Yeah, I think some of the biggest shift that we've seen over the past few years, as you say, is that kind of two-way dialogue, and the importance of kind of care planning, actually, and starting to think about everybody who is involved in that patient journey. So we now, it's quite regular practice that if there is a particularly complex patient, maybe patients who are quite transient, moving around the city or the wider kind of country, that we will get together and do some kind of care planning. And we have a platform available in London that's a kind of universal platform that treating teams can upload a specific care plan for that patient that our crews can access. And then also we have in LAS a dedicated frequent caller team who do amazing work, looking at the unmet need that a lot of our patients who are frequent callers have. So yeah, I think that's been a real key shift here, and I think part of the kind of learning that we have is around each other's kind of roles and remits. And I think I was probably very naive when I joined the ambulance service 10 years ago, around how the ambulance service has to operate, and rightly so, because it's an emergency service, and then how that can sometimes be at odds with the mental health trust, and they may be quite kind of containing in regular appointments and agreed kind of contact, and then the nature of the 999 call system means that you can access the 999 service at any point. So yeah, so I think it's been really key for us to learn about each other, actually. And sometimes a mental health trust or team will come at it that why can't we do this, and we're like, well, it's not possible because we're not a mental health trust. So it's about that real understanding of kind of each other's kind of roles and what we're here to do as well. And initially, when we set up the mental health cars, we did have staff who were, it was like a workforce sharing, so we would have staff from the mental health trust to come and cover the mental health joint response cars, and that was good in terms of them having kind of access to the patient records, so we didn't have to call up the single point of access, and it just makes things a bit leaner. So I think there's more kind of integration that we could do, definitely, and that's kind of work that's ongoing that Dan and I and other colleagues in the trust are kind of looking at. So yeah, it's just about having those contacts, actually, and having somebody that we underestimate, having somebody that they can pick up the phone to us as a team and say, look, we have this patient that's calling ambulances a lot, and vice versa, like, shall we get together and have an MDT about the person to see kind of what the need is and how they can best be helped, and then it helps the patient to have the same kind of plan as well reiterated to them, because quite often I think historically we were giving very mixed signals as organisations, to patients. So having that single plan to work from is really valuable, and again, it helps the patient to feel very contained and validated that we're all talking and doing our best here. Yeah, so it's not so destabilizing.
No, indeed, absolutely, and like you said, it's the strength in numbers, really, to articulate frequent callers, and actually, like you said, multifactorially, just put a plan in place, look at the wider aspects, because there's useful information from even from GPs and indeed primary care colleagues that can feed into that plan. Absolutely. So a couple more questions. One, Dan, would be, is there a case study that comes to mind really that you or indeed Carly has seen that actually has had a positive outcome, and indeed is one of the pathologies that we've maybe mentioned above that actually showcases, I guess, in a way, just an optimal treatment plan that reach back into the community mental health services just to facilitate either an alternative care pathway or indeed just that optimal outcome for a patient.
Yeah, absolutely. So I've got a case. I've got a case that came to mind actually during Carly's answer around sort of psychosis presentations that I think would be interesting to discuss. And actually, sort of by as luck could have it, it was a job that Carly and I went to a little while back. So I'll summarize, and obviously if Carly has any other reflections about the call, if you can remember it, then obviously that'd be like that. Yeah, it'd be great to get your thoughts on it, Carly, as well. So yeah, a little while back, we were working on the mental health car. And we were dispatched to a 999 call for a patient who was threatening. It came down saying that he was threatening his mum with a knife. So we arrived on scene. Police were obviously already there due to the sort of the mention of the knife, and we found that the patient was in the attic, as described, sort of brandishing a knife, and that his mum had been hiding in the kitchen. The Obviously there were sort of very real threats of harm both to himself and obviously being made to his family on scene as well. And sort of on our arrival to the patient in the attic, who sort of still had the knife, and the police were up there. The patient was sort of obviously extremely unwell and sort of floridly psychotic. It was sort of very obvious from his presentation that this was like that the patient was very unwell. And sort of we were leaning towards sort of going down the route of this is sort of potentially like an ABD or an acute behavioral disturbance presentation. So again, as at this point on the incident, the police on scene were great, and were sort of, they hadn't sort of rushed to sort of try and they had sort of hadn't rushed into a situation that may have escalated this sort of the patient's presentation, but they also hadn't quite sort of identified sort of like that this was sort of like an illness, and they were sort of they're sort of starting down the route of sort of treating this as like a hostile person with a knife, sort of rather than an unwell person. So we had a good discussion sort of with the police, and sort of let them know that actually we think this person's sort of really unwell and in need of care, and sort of tried to bring it back to the patient, and obviously weighing up that there's with them that we needed to sort of come up with a plan in which the patient gets the care they need, and everyone's safe, and we sort of the knife is removed from him, and as well, but likewise that the however the call outcome ends, that the mum and other family members are safe, and also if possible a plan where the police are not putting themselves at risk. So yeah, so we're sort of trying to weigh up with them sort of like the best way forward, and sort of trying to engage with sort of de-escalation techniques directly with the patient. So we spoke to the local mental health line before the police sort of took any action. I think as long as we were keeping our distance, sort of like the patient was sort of keeping their distance. So I think it's just worth noting that like you know with the patient's illness, and how they were perceiving sort of reality in that moment. I think from their point of view, this was defensive behavior. We were all in his safe space. This wasn't, and the same for his mum. How he was perceiving things, that the mum was in his safe space and he was feeling threatened. And I think it's worth sort of bearing in mind, that sort of, what is going on in the patient's mind in these times. So yeah, so we spoke with mental health services, and unfortunately, on this instance, because of the risk, because of the knife, and because of like the sort of the level of risk to the patient harming himself, unfortunately, they were unable to come out and assist immediately. But they were able to sort of provide lots of really important information over the phone. We were able to sort of establish like past history and previous presentations. which I don't want to go into too much, just to sort of make sure we keep this, anonymous for the patient's sake. But yeah, they were able to provide us like really valuable information. And we were able to sort of form a plan sort of before this, tipped into like that, a sort of a full ABD presentation. And actually, importantly as well to note, because again, we only ever see these snapshot of these patients' lives, but we also learned that when well, the patient has a great relationship with his mum, and it's a stable household, and so yeah, just so again, just sort of keeping in mind like the human element of these things. So as we were discussing on a plan with the Mental Health Trust, we were able to essentially come to the conclusion that they were unable to provide a safe response, in a time frame that we could mitigate the risk around sort of like the patient harming either himself or somebody else, sort of in a time frame that they could actually realistically come out and do a mental health fact assessment. The provision just sadly doesn't exist. Despite any system in place, we don't live in a perfect world where these things can come together as they always should. So their advice was to actually convey under the Mental Capacity Act, sort of due to the level of risk, and no other provision. And I think like in terms of positive outcomes from the case, I think first of all, we were able to identify the least restrictive and best interest option for the patient, which because of that risk to harm themselves, and because we were unable to rule out of physical health presentations, and the patient was very sweaty, and it was possibly going down that sort of ABD route. It was agreed through all those on scene, including when an ambulance sort of backed us up as we were sort of thinking this would be a conveyance, and the mental health services, we've sort of in agreement that sort of conveyance to ED was in the patient's best interest. Fortunately, with information from the Mental Health Trust and from sort of like the de-escalation skills that we were able to bring on our team's car, we were able to de-escalate the situation enough that the patient sort of gave up the knife, and sort of agreed that they'd sort of come with us, and as a result, the police were able to assist with getting the patient to hospital, with absolute minimal restraint, and helping the patient down the stairs. And I think anyone working in the pre-hospital setting has sadly seen cases where sort of like the alternate is true, where sadly we've seen things escalate and put the patient in much more risky situations, and the police in much more risky situations as well, as they've got to sort of like get close to somebody with a knife, and we know that active restraint for the patient, that the outcomes can the mortality rate increases significantly. Likewise, out the house, once we sort of got the patient out of the house, his demeanor changed significantly. He was extremely unwell and risky still, but he in himself he seemed a lot less distressed, and he seemed more at ease. So it was good to see sort of like the for whatever reason, getting him out of this space that he was extremely distressed in was able to improve something for him. And then fortunately, in a dream world, there in a dream world, maybe if there'd been some provision that within the mental health act that the mental health trust could have offered us, that and we could have safely got left the patient at home, then a community referral may have been possible. It wasn't in this case, sort of for reasons we've talked about, but fortunately at hospital, it was a very smooth handover. We sort of, as something we mentioned on a previous episode, we were able to speak directly to the psychiatric liaison nurse there as well, to sort of ensure that the mental health team in the A&E was fully sighted, and they were able to sort of move the patient swiftly to a bed, protect some of their dignity, and get them out of the hallway, as we were queuing for triage. And I think they were sort of following up, arranging sort of follow-up assessment, sort of quickly for the patient at the point we were leaving. So that's sort of like the job. But Carly, I don't know if you have any other thoughts or reflections that come to mind.
Yeah, I think the key, there's two things really for me. And then it was also about supporting the mum and explaining to the mum, because I think there'd been obviously a history of, being admitted to hospital under the Mental Health Act. And that in itself can be traumatizing because you're effectively told, you can't leave this ward, you can't go to the shop, all of that stuff. So kind of reassuring the mum, because there's kind of police and ambulance staff in her house. And then also just explaining there's three things actually. Also explaining to the patient what we had done and why we had come to that decision, and then explaining that we were making that decision for him because we felt he couldn't make that decision, and we understand it's not what he wants, but we want him to get better, and we were worried about, as Dan said, he's sweaty, and just kind of explaining that. And that sounds really obvious, but I think in the heat of the moment, if you're describing like a knife and police, and it's actually explaining like why we've made this decision, and hopefully and show that patient that we are advocating for them, and like we have, obviously we knew that community treatment would be futile at this point, but we try it so we can explain to the patient. And then also the third thing, and I think that you were the APP on the call, the managing the police actually, because obviously the police's training is to maintain kind of safety is one of their kind of key principles, isn't it? And actually getting them on board with, actually in this situation less is more. And the call that you backed us up on one time, I don't know if you remember, there was a patient where it was quite similar, was brandishing a weapon, and the police were not so open to looking at things in a different way, and they wanted a kind of quicker hands-on approach, which made things kind of escalate, to the point that the patient had to have some sedation. And so actually, trying to get the police on board that actually, yes, he has got a knife, but we've got eyes on him, we're at a safe distance, let's just show him that we're quite trustworthy because he's psychotic, he's had probably negative experiences before. So yeah, I think that they were the kind of key things for me. And yeah, it's not an example about kind of keeping someone at home, but it's an example that it's about advocating for that person. And actually, yeah, that person will remember that. They will, they might not at that point in time, but once they, are getting better and processing what happened, like they will remember that we made them feel like supported and that we were trying our best in a difficult situation. Yeah.
Yeah, indeed. And to both of your points, actually, and the palliative and end of life care team said this around you, once you shift one, if the patient reaches an end point, a care is extended to the family, but B, it's about actually slowing things down because Carly and Dan, as you were saying, sometimes if you have got the clock in mind and you're time focused, you can actually push the patient to, rather than de-escalate, to Dan's point, and verbally de-escalate and get them back on side. It's you can actually push and make things worse, and like vicariously, either through the police or another agency. So you're right. The taking a step back from a time-based approach, really slowing things down, like so taking time to win the patient over, to really harness those 1% of, reach to the family, to maybe to their care team and the mental health community team, but fundamentally to the patient, and start to really win them over. Because to Dan's point around, you can in a card array of patients, you can avoid the the risks of sedation, you can avoid having to pharmacologically intervene, and you can actually get to a better endpoint. And Carly, to your point, advocate for the patient, have seamless handover in hospital, and really utilize the MDT approach, which involves the police very much so, but by slowing down. And actually, you're absolutely right. That actually you can, an optimal outcome is to sometimes, because we are very time based professionals, and we're monitored on time, time to scene, time from scene, time at scene. But actually, these type of calls, it's really putting the clock aside, building that rapport, and so just looking at the leverage points where you can leverage relationship and where you can start to win patients over. And to both of your points, some patients will be beyond that. There won't be those entry points into the pathology because it's a florid case, but there's plenty of opportunities with a number of patients where there is those points, and you can absolutely alter the trajectory of care and stop the off ramp the risks of sedation and or otherwise. So I think it's a great case, actually, involving multiple teams, but fundamentally involving the patient. Just through the adage of time, I think what we'll do is leave it there. That was a great case study, and just really brought out some of the attributes of non-technical skills, and to both of your points, the communication. But listen, I just want to thank you for these 3 episodes, both Dan and Carly, because we've walked through some pathologies, but we've walked through some case studies, and we've walked through some really fundamental principles just to enact on scene. And something that's both come through from both of you really is, you're never alone in these cases. So if you're out of options, just pick the phone up, ask for the mental health team, the response car, if they are there, or indeed the mental health professional in the control room, just for a different opinion and some extra advice. And I think that's such a powerful pivot. But just so listen, thank you both really for journeying through these past 3 episodes, and it's been as informative for me and hopefully for listeners. So thank you so much.
Thanks for having us. Hope it's
Thank you
been
very much.
useful. Yeah.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.